Hi, good afternoon. It is now 2 o'clock Eastern Time, and you have joined the webinar on creating buy-in, best practices for collaborating with referral sources on crisis stabilization units. To allow for additional sign-ins past the hour, we'll be starting this webinar in just a few minutes. Thanks. Good afternoon. Thank you for joining today's Justice and Mental Health Collaboration Program webinar on creating buy-in, best practices for collaborating with referral sources on crisis stabilization units. My name is Hadley Fitzgerald, and I'm a Senior Policy Analyst at the Council of State Governments Justice Center, and I will be co-moderating today's webinar, which is hosted by the U.S. Department of Justice, Bureau of Justice Assistance, or BJA for short. To give you an overview of today's webinar, first we'll do introductions of our co-moderators from the National Police Foundation, as well as of our panelists, who include representatives of local behavioral health and law enforcement agencies, as well as people with lived experiences from jurisdictions around the country operating crisis stabilization units, or CSUs for short. We'll then review our goals for the webinar and then turn over some questions to our panelists for discussion regarding best practices to encourage buy-in from potential CSU referral sources. Just some housekeeping items to start. Anytime during the webinar, you can ask a question by placing it into the Q&A panel on the bottom right-hand portion of your screen. This includes both technical and content-related questions. We will try to reply to technical questions in the chat window as we go. For the content-related questions, we'll keep a running list and address them during the Q&A segment of the webinar. And we'll do our best to get through as many questions as possible. If you do encounter technical or audio problems during this webinar, please call WebEx technical support at the following number, 1-866-229-3239. And please understand that there are some technical issues you may not be able to resolve. We are recording the webinar and we will post it to our website by the end of next week. So joining me from the Council of State Governments Justice Center is Marilyn Leake. Marilyn is a Senior Policy Analyst in the Behavioral Health Division. She works on county-based initiatives that are focused on improving outcomes for people in the criminal justice system who have behavioral health disorders. Prior to joining the CSG Justice Center, she served as the coordinator for the mental health and drug court programs in Prince George's County, Maryland. Joining us from the National Police Foundation is Dominique Burton, Project Associate. She supports the local programs team and various projects funded by the Department of Justice. Her areas of expertise are in criminal justice related to policy development and administration, intergovernmental relations, and community engagement. Rebecca Benson is a Senior Project Associate. She provides analysis and training and technical assistance for law enforcement and community collaborative programs around policy, procedure, and practice. Rebecca has developed and implemented several collaborative local, state, and federal programs that have brought partners together from public safety, community service providers, education, mental health, substance use, business and private sectors, and faith-based organizations. Chief Frank Straub is the Director of Mass Violence Response Studies. He joined the NPF after a 30-year career in federal, state, and local law enforcement. He specializes in the areas of mass violence prevention, school violence, counter-extremism, and first responder health and wellness. He is a licensed therapist in Michigan and serves as a clinician on the Calhoun County Sheriff's Department peer support team. Joining us today for our panel discussion are Angela Warren, who is the Paraprofessional Service Coordinator for the Behavioral Health Crisis Center at Advantage Behavioral Health in Athens, Georgia. Angela began working with Advantage in 1999 as case manager for the Assertive Community Treatment Team. In 2002, Angela became a mental health certified peer specialist. She began working with leadership on the Behavioral Health Crisis Center when it opened in January 2018 to develop policy and procedures, best practice crisis intervention techniques, and a comprehensive peer specialist program. Angela has over 20 years of direct and indirect experience working with behavioral health individuals in a crisis setting. Sheriff John Mayer is no stranger to law enforcement. In August 2014, he was elected to serve as the sheriff of Madison County, Tennessee, and was re-elected in 2018. His entire working career has been devoted to this profession, with 38 of those years with the Tennessee Bureau of Investigation. As sheriff, he oversees the operations of 358 sworn in civilian agency personnel. His agency utilizes a comprehensive training strategy, including CIT, and supports processes for their law enforcement personnel to identify and connect appropriate people to 24/7 crisis stabilization units. Madison County is one of several innovative jurisdictions who serve as a peer-to-peer law enforcement mental health learning site in collaboration with the CSG Justice Center and BJA. Prior to his election in Madison County, he worked for the Tennessee Bureau of Investigations as a special agent assigned to the Drug and Criminal Divisions, and ultimately as the special agent in charge of the Criminal Investigation Division. He was also previously employed as a police officer for the Bells, Tennessee Police Department. Kim Parker is the Director of Crisis Services at Pathways Behavioral Health Services, also from Madison County, Tennessee. She has been employed at Pathway for the past 21 years. She previously worked in the social service field as a coordinator of services for the developmentally disabled in Little Rock, Arkansas, and manager of the Family Crisis Program with the Tennessee Department of Children's Services. Kim has served as adjunct staff in the social work departments of Union University, University of Memphis, and Bethel University. Lieutenant Sean Hill is lieutenant for the Santa Barbara Police Department and a PhD student at the University of California, Santa Barbara in the Department of Communication. He earned an MA in Criminal Justice from Arizona State University. He currently serves on the Community Policing Committee for the International Association of Chiefs of Police, served as a member of the BJA Executive Session on Police Leadership, and is a National Police Foundation Policing Fellow. Most recently, he co-edited the interdisciplinary International Roman and Littlefield Handbook of Policing, Communication, and Society. Thank you to all of our panelists for joining today's webinar. Next, I'm going to give you some background on the Council of State Governments Justice Center. The Justice Center is a national nonprofit, nonpartisan organization that combines the power of a membership association representing state officials in all three branches of government with the expertise of a policy and research team focused on assisting others to attain measurable results. This slide describes a little bit more about our work style, which includes a commitment to bringing people together from both sides of the aisle, from federal, state, and local leadership from across the country in order to foster collaboration. and driving the criminal justice field forward with original research through in-depth data analyses, as well as interviews of people on the front lines of the criminal justice system, and building momentum for policy change, and finally, through providing expert assistance with our on-the-ground training and assistance, which helps states and local agencies translate the latest research into policy and practice. Today's webinar is part of the Justice and Mental Health Collaboration Program, which many of you may already be familiar with if you currently have or have had in the past been awarded a JMHCP grant. The JMHCP program promotes innovative cross-system collaborations and provides grants directly to states, local governments, and federally recognized Indian tribes in order to improve responses for people with mental illness and substance use disorders who are involved in the justice system. We also wish to introduce the Bureau of Justice Center, the funder for this work. You can read this mission statement of BJ on this slide. And now I'll turn it over to Dominique Burton to provide an introduction on the National Police Foundation.
Thank you, Hadley. The National Police Foundation's mission is to advance policing through innovation and science. It has been on the cutting edge of police innovation for the last 50 years since it was established by the Ford Foundation as a result of the President's Commission on the Challenge of Crime in a Free Society. It is the oldest nationally known nonprofit, nonpartisan, and non-membership driven organization dedicated to improving America's most noble profession, policing. Next slide, please. We will be going over a few more items before we get to our discussion. We'd love to go over our themes and the mission for this webinar. Goals for today. We want to foster discussion to create buy-in. We want to provide a peer learning opportunity for jurisdictions operating or developing a CSU. And we want to share resources from the field of best practice solutions to further advance current efforts in developing and operating CSUs. As we know, an increasing number of jurisdictions are exploring ways to expand or improve their crisis systems responses when interacting with people experiencing a mental health or substance use crisis. One option includes CSUs, or similarly designed models. While CSUs are a great diversion opportunity, implementation can be very challenging. Having buy-in from referral sources, particularly law enforcement agencies, can help strengthen this critical diversion option while improving the jurisdiction's overall crisis response system. Next slide, please. I'm going to turn it over to Rebecca Benson to discuss our themes and to get into the discussion with our panelists.
Hi, everyone. Welcome. We're so happy that you're here. This is something that the panelists here today have been working on for quite some time, and we'll in a minute get into a lot of the nuts and bolts on how they built up this collaboration. But we're going to kind of try to steer the Q&A into a few different themes. So we want to talk about the developing and the nurturing of those relationships, because I'm sure all of us are aware that they usually just don't just start. There's a lot of background and there's a lot of work and development that goes in prior to a CSU kicking off. We're going to touch a little bit on sharing data and other information, because that becomes, again, as you all know, can become quite complicated in some areas. We want to talk about training, cross-system training, and how you all manage some of that. We also want to talk about incorporating those with lived experience into the crisis center models. That's something that I think a lot of places are really trying to do more and more, trying to figure out the best ways to fit those elements into their units. And we want to talk about some of the barriers and challenges that come and go and come back again, and new things that pop up. And then we just want to talk about also some of the successes that different places are having right now, and what we think might be contributing to that, so we can help each other sort of model those things. So again, we really appreciate you being here. We know you all are doing a lot of really challenging work, really meaningful work, and something that's very critical to your communities. So I kind of feel like we might want to start before we go into Q&As. If you can go to the next slide, please. We can go to the next one. I think it's just a repeat. I think maybe we'll just start off with Sheriff. If you could, and your team, and Kim, whoever you guys can both take a couple minutes. If you could just give us a little bit of information about your jurisdiction, and then also about your crisis unit. Things like location, hours of operation, what kind of generally what your staffing and services look like, please.
Our services, as we talked about it with crisis, is 24-hour services. Actually, because of the way the crisis center is set up through West Tennessee Healthcare, it covers several counties, or near about half the counties in West Tennessee. So therefore, departments throughout West Tennessee actually can use the crisis center and call it on the hotline and bring people in immediately. We have a big collaborative unit in Madison County, and we meet pretty regularly, except for when COVID was going on, bring in new ideas. Our jail, we rely not only in the jail, but on patrol and CIT. We have numerous CIT programs going on to train officers, and not only officers, but even our people that are in the fire and in EMS. And then we also have our mental transport unit, which actually entails and involves the crisis center with Kim and them at Pathways, and we do all the mental transports for our county and for some other counties. And we actually were the pilot program for mental transport. And by doing so with the CIT, we're able to softly take the individuals when they need to be transported or moved from one location to another because the officers are well trained. Also, we have an EMR that is on the two-man team on each shift. So if there's a transport, we have medical personnel on board, plus the officer who is well trained, and they're both well trained in CIT. So that's a very important thing, and it interacts. We're able to interact real good with the crisis center, and they have a mobile crisis unit. And Kim can continue from here.
Okay, thanks, Sheriff. Yes, as far as our crisis continuum services, we do have our mobile crisis response team, and that is of master's level and licensed mandatory pre-screening agents in the state of Tennessee, able to do commitments on site if needed. We work with that mobile crisis response. We do not have the law enforcement responder team. However, we work very closely with them, and on specific cases, our mobile crisis response team is able to go out with our law enforcement on cases and send our MPA, the mandatory pre-screening agent, out. We've also been able to send a psychiatric nurse out when needed to be able to de-escalate, assist with the de-escalation on scene, and get them the services that they need as well related to our mobile crisis response. The other part of our continuum is our crisis stabilization unit and 24-hour walk-in. Our location is in Jackson, Tennessee, which is the hub of pretty much 21 counties, rural counties in West Tennessee, excluding Shelby County, Memphis. And we're able to reach out to those counties. Currently, our 24-hour walk-in center is staffed with an RN as around the clock, and psychiatric technicians, and a crisis responder on. We are looking to expand that a little bit more and provide more on-site social services. But we also have a medical provider, whether that's a psychiatric nurse practitioner or a psychiatrist, on call or available on site during business hours and on call afterwards, to be able to provide medications and medication evaluations as needed for those individuals. Once they come in through our walk-in center and those services are provided in the walk-in center, we are then able to determine the most appropriate level of care, looking at the least restrictive. And our walk-in center operates for the entire community. It is also considered a pre-arrest diversion. So we have, as Sheriff Mayer was talking about, those officers that are trained in CIT. We have the police departments, surrounding police departments, sheriff's offices, surrounding sheriff's officers, state troopers, fire, TBI. Those officers are all come through the learning site to receive the training. And Jackson, Tennessee is located right off of, right on I-40. And so state troopers and multiple people are able to respond to these cases and bring them in to our walk-in center for appropriate assessment and to place in the least restrictive environment. Other options that we have with our walk-in center, we have access to admitting someone to a 15-bed crisis stabilization unit, or also a crisis detox. We see a lot of individuals coming in with, opioid overdoses once they've gotten medically cleared from any of our local emergency departments. We're able to bring those in and get them in the most appropriate place as well. And so we is talking about your other part of the question, working with communities. We work with all of the areas of law enforcement to provide that pre-arrest diversion service, as well as diversion from local emergency departments as well. So we work with our emergency departments. We do also work very closely with TMHCA, Tennessee Mental Health Consumers Association, and they provide us with peer specialists for our walk-in center, as well as our crisis stabilization. We also have peers. We are connected, Pathways Behavioral Health Services, connected to a larger organization, West Tennessee Healthcare, and we have been able to create recovery navigators, and we've embedded them into our emergency departments to do that initial contact with them and their peer recovery specialists, and they're able to do that initial contact and then bring them, make that referral to us with our walk-in center to provide that most appropriate care. And I would say the collaborative effort that Sheriff was talking about, meeting on a monthly basis, bringing in other community. NAMI is very highly active with our collaborative. DBSA, Depression Bipolar Support Alliance, in order for it to work as well as it has, we have to have all players involved. And so we also have people from recovery courts and things, other organizations and agencies such as that.
That's amazing. Thank you, Kim. Thank you, Sheriff. We actually met Sheriff years ago at the when you guys joined as a learning site, and it sounds like things have just continued to improve and increase there. So it's really impressive what you all have done. I just want to kind of go back to a couple things that you said, Kim, if you don't mind.
Okay.
Those 15 beds, how kind of where are you guys operating? Like, are those beds mostly full, or how is that? What's your sort of, not what's your caseload, but what's the activity level generally for you all?
We, at the 15 bed, we average daily census of about 12, and that is, you would think we would stay full. There are times that we're very full. And again, we're covering a rural area, and also reach out to the sheriff's office and police departments in our surrounding counties, and they also bring people in. We can take people on detainers while they're in jail. And so we also have the other services that are available to us. We don't always, because we always try to look at the least restrictive. And so we have that crisis detox center. We have 18 beds available for crisis detox. And so a lot of those individuals will go there. And that is we stay pretty full on those beds as well. And so, yeah, very, very busy. And with the crisis stabilization unit, it's a 3 to 5 day stay. Our average length of stay is about 3.45 days. Getting them in there, getting them connected to community resources, and then following up with those individuals.
That's interesting. That's great information. I know that a lot of collaborations are still kind of, I shouldn't say playing with, but like trying to figure out the piece of what you go after first. Is it the substance use, or do you like, so I know that's an interesting sort of dance, and I imagine because you offer all of those services, you're probably doing that every day, trying to figure out where to prioritize.
Exactly. Yeah. From the very beginning, we realized that in order to be successful and effective, that we definitely have to have a co-occurring model and be able to address both of those. And so where our crisis detox is more of a medical detox. And then we can also utilize our crisis stabilization unit for those needing social detox, but also, they're self-medicating. And so looking at the most appropriate psychotropic medications that they need. And so our crisis stabilization unit is staffed with psychiatrists, psychiatric nurse practitioners, master's level clinicians that are both LADACs, licensed alcohol and drug abuse counselors, social workers, to be able to address both of those things. And just, we utilize that no wrong door concept to look at meeting the needs of those individuals coming in with co-occurring. And it's easily all the ones that walk in through our walk-in center, I would say about 80 to 85% of those are dealing with co-occurring issues. So
yeah, a good portion of those, sounds like. Back to the walk-in, well, or handoff situation. So how does that work from the law enforcement side for taking someone in? Do you guys, how do you get a heads up, or do you?
we do, yes. Through our collaborative, we've kind of learned a lot of things and a lot of tips and things, and I think it's very important. And Sheriff Mayer talked about his mental health transportation team. They are also that same team that will respond to the incidents out on the street that are potential mental health or substance abuse crisis. And so when they're out on the scene, as I said, they'll call our nurse at our walk-in center and say, hey, this is what we've got. Immediately, if it's one that we're familiar with, we're pulling up information and we're prepared on, how to do that and have that warm handoff from law enforcement. So they bring the patient in, and it's like, kind of an introduction with them, because on the scene, these guys are really great at establishing that rapport and de-escalating. And so they bring them in just like they're really good friends with them and introduce them to us. And once they do that, they're not, years ago, they would have to take someone to the emergency department, law enforcement, and stay with them. And so once they've done that warm handoff, they're free to go back out, you know, and patrol the streets and do what needs to be done, you know, from law enforcement perspective. And so, but yeah, it works really well to have that. They call us and, you know, and let us know what, you know, who they've got, who they're responding to, what behaviors that they see, because they're highly trained. Later, Sheriff Mayer may talk about kind of doing the advanced CIT services or training. And so they're very well trained in recognizing symptoms and different things. And so they're able to tell us, hey, we think this is substance-induced psychosis, you know, those types of things of what's going on with the individual. And it really helps prepare us if we've got them bringing in someone who's very aggressive. And in our waiting area, you know, we have in certain areas where we're doing assessment, maybe we're doing an assessment on an elderly person, it allows us to prepare the area to have a more therapeutic environment and move people around to be able to, you know, to meet the needs of each individual.
Sheriff, do you tell me about those teams that are bringing people into Kim's Center? Do you have enough? Do you have enough
No,
on your team?
well, we're actually have 3 people. Actually, they're deputies that are assigned to the transport unit, but we also we have ones that we're paying overtime to work another shift. So we've got 24-hour coverage. And I think that's very important. They're all well trained. As Kim said, some of them actually have their masters in mental health. The other thing that we have is in our jail, we actually have counselors and a clinician that's in the jail, not full time, but when something comes in the jail, then they're right there at the jail to start working with them. And then if we need to move them out to the crisis center, stabilization unit or something, then we're able to do that. And we also use telemed in our jails and in the crisis centers. So that really helps on the transports of these individuals. And then in our jail, and I'll also say the big help is the state of Tennessee, the Department of Mental Health. The commissioner is great to work with and has helped us. I can't tell you how much, but that's the key to this too, is to have the buy-in with the state and be able to work with them. And her mission is to help everybody. And that's, if you have that buy-in, that's a big plus, because it helps the whole program and it helps the funding. And so I think that's, and you're working with the state facilities also, because you have them on board with you. So in your collaborative, we've got, I think, 20 or more departments across, West Tennessee that are a member of our collaboratives. And NAMI, we work with NAMI. It's just, you've got to have a buy-in from everybody in order to do it. And the training is most important. And CIT, I think, and the way we do ours, and we have the advance, and then we have train the trainer, and then we have additional courses on that, and then mental health first aid. And we try to train everybody. And we've trained over 700 or 800 officers and jailers. And you got to have that also, because in the jail, you really have a serious mental illness problem. And so they've got to recognize that.
Just to follow up, Sheriff, the deputies that you have on these teams, how did you pull them in, or did they sort of self-select for this collaboration? How do you find the right officers or the right deputies for this type of work? Because we all know that it's not for everyone.
No, that's true. we actually, some of them had their degrees after graduating from college. They came in and we kind of zeroed in on them. But then also we did the CIT training. We saw how they performed in their class. And we also wanted to make sure that they wanted to be a part. So it's a volunteer mission, because if you don't want a part, and we've got some that have been in and even have been in the mental health field who are back out on the road and are working out on the road, or not on the transport team any longer, but they wanted to get out and do other things, but they're a big help because they're already trained. And so if something happens in their area or their zone, they're right there to respond. And then the other team comes on in there, and it's like Kim, that handoff, that soft handoff, the way you treat those individuals is most important. And that's the key to all of this, but it's the working together of everybody. You know, one agency is not the leader. You know, we all pull together to be one, and we are part of the mission together. And so that's the key.
Thank you, Sheriff. Lieutenant Hill, I don't want to leave you out. If you are there, if you wouldn't mind giving us a little bit of background on what's going on in San Diego County, that'd be great.
Sure, absolutely. It's in Santa Barbara.
I'm sorry.
No, that's okay. I've been like an audience member taking notes from all the information I've already learned from the sheriff and from Kim. So I'm having a great time. We are a user of a CSU from the county, so I have a different perspective. So we have a municipal police department that is a user of the county's program that's run through their behavioral wellness. It's a 24-hour operation. It is staffed for 4 patients, but they have the capacity for 8 if needed. There's a psychiatric nurse for every 4 patients, as well as social workers and peer specialists. There's obviously they're addressing the things commonly associated with CSUs, psychiatric medication for people, mental health and crisis who need counseling, kind of setting up the person for ongoing care. There's also places for shower and laundry in a kitchen area. And it is a limited, something I heard different is it's limited to 23-hour stay, so just shy of a full day. And I heard I think Kim mentioned the 3 to 5 day window, so that would be something different. I don't know the background behind that for the county. We have limited walk-in hours, so it's a little bit more limited. I heard, I think I understood it to be for the sheriff's, it's a 24-hour walk-in, but they have a limited walk-in. However, there's a mobile crisis unit that operates with the CSU, and referrals from law enforcement is 24 hours a day. We also have a co-response unit. So one of our officers is teamed up with a clinician and works in conjunction and I guess collaboratively with the CSU as well. So we have our own co-response officer with a clinician out in the field to respond, as well as a mobile crisis unit from behavioral wellness. And I'm happy to elaborate on anything else if you like.
Thank you. No. So those teams, what are your team size look for your mobile crisis response unit? How many officers do you have for that?
So we have, our agency has co-response, and it's just one officer and a clinician.
Oh.
And then the county has mobile response that covers 7 days a week, and that doesn't have an officer attached to it. They are field mobile crisis units, so people who have training. I think most of them are clinicians, but they don't have officers attached to them. The law enforcement officers call the mobile crisis unit out to them when they're in need, if the co-response unit's not available. But our agency itself has one full-time officer assigned to a co-response unit.
Thank you. I also just want to add before I continue on with questions, Chief Straub, if you need to jump in at any point, please do. So I kind of want to go back to, and this may be more of a question because I'm not sure, Lieutenant, if you does the county have a lived experience component to the program?
They have peer specialists. Is that what you're referring to?
Well, I guess. I mean, I think we're sort of thinking of it more in terms of like family members or those who are in recovery from a variety of ways. I mean,
Yeah,
I guess that's.
I'm not sure I'd be able to expand too much on that. It's not our operation, so I just can provide you from the user standpoint.
Sure. What, Kim, if you want to, do you mind telling us a little bit more about yours, the component to your program with that?
The peers, yes, we have, as I mentioned, we work with very closely and collaborate with Tennessee Mental Health Consumers Association, and they have the people with individuals with lived experience that go through peer specialist training and receive certification. And on our crisis stabilization unit, once they come in through our walk-in, that is like a 23-hour observation. And if they need beyond that, they would go up to our crisis stabilization unit, which is then a 3 to 5 day stay. And while on that unit, they will receive services, all the other services I mentioned, but also groups and individual time with the individual with lived experience through that Tennessee Mental Health Consumers Association. But we also hire within our organization, we hire those with lived experience as well. And so we have them available as they're in our walk-in center, being seen by mobile crisis. We can always connect them to one of our certified peer recovery specialists with a lived experience and get them connected where someone that's experiencing chronic mental illness, SMI, they are able to get connected with those peer recovery specialists and then follow up with going to we have peer centers in our area, and we operate those completely peer-led. And so throughout the week, they can go to those peer centers and do different things, participate in psychosocial rehab and things like that at those peer centers.
Thank you, Kim. I wanted to actually, Dr. Straub, if you want to jump in here, I'm going to get my next batch of questions.
Sure.
Right.
So for the police officers and sheriff on the line, this is tough stuff for police officers to digest, to accept, right? I think during my career, my 30-year career, I often heard, this isn't really my job. I don't want to do it. It's time consuming. How did you sell, if you will, this program within your departments, and how do you justify it, if you will, to your officers that it's a worthwhile endeavor? Do you keep statistics? Do you look at recidivism rates? Do you look at reductions in calls for service? So first, how did you sell it? And second, how do you continue to sell it and maintain buy-in? Because it sounds like you're both departments are doing incredible work.
Well, from our standpoint, I think the way we sold it and the buy-in is because of the education that they receive going through CIT and some other training, and then being a voluntary, wanting to be in that division, not forcing anybody, but they learn how to deal with the people. Some of them, as I said, had their degrees in mental health, their masters, and they want to help people. You can't just pull somebody in there and they don't have the desire. These deputies we have the desire to work in that field, and some of them actually continue education hours in that field. So I think that's important. You've got to let the person fit the job, and the job fit them. But you got to have you can't force anybody. And so after a time, some of them would like to get out. I mean, you're doing it, as you know, day in and day out. Sometimes you need a break, and if they need a break, they can take the break and be out for a little while and then come back in if they want to. But the thing is, they're training others as they're going through this job, and so you've got others that want to join in. And the same way right now, where we're paying overtime for the other shifts, those people want to be a part of it, and that's important. And some of them have been the trainers. The other thing is, it's the funding. The state of Tennessee has been so gracious, and the Commissioner Williams and them have been so good for us because the state of Tennessee is a motivator. I mean, they're trying to get on the cutting edge of everything in advance, and so that helps because we are a partner and of every in law enforcement, and that's important. So that, to me, that helps sell the program. We look at how many people are coming back. Just like in our dispatch, we know if we get a call out there and it's a mental health call, we know a background about that person before the regular deputy may arrive on the scene. So it's I guess we just kind of take it for granted because we've been doing it for a good while, and we had some kinks in it to start with, but you have to work those out. And once you get in there and you get the buy-in from everybody in the collaborative, we can just reach out and contact these other people who are not here on the webinar, but other agencies in mental health that are part of our collaborative. So to me, that's just the key.
Thank you, Sheriff. I do have a follow-up question, and then I'd like to hear from the lieutenant from Santa Barbara. But have you found these programs have reduced your use of force incidents in the community? Oh,
yes, it is, no doubt. I mean, it's we don't just train these officers that are assigned to the unit. We train all our officers, and in de-escalation and all. That's another set of training altogether. But the use of force has drastically gone down, and this has been going on for several years now. And so, to me, that's the key. That training is so important, and then they understand how to deal with the person. And it's not like the old days, and I think Kim can tell you too. I mean, it's that communication and knowing how to care for somebody. Like in the mental transport unit, we have the specialized vans. They're set up. They're not marked as police cars. They're not marked as anything. The officers are dressed down in polos and all that. So that makes a big difference too. When you're approaching somebody that is going through a crisis.
Great, thank you very much, Sheriff. Lieutenant, can you share some thoughts with us about your department and how you keep officers engaged and interested in these programs, and what effect you think these programs have had on the culture of your department?
Yeah, Dr. Straub, I think you hit on some really huge points. So I'll speak to it from kind of a collateral position from the sheriff, in that we don't have, robust units and systems built in. We're a smaller department. So we kind of have to have buy-in from everybody. The self-selection that was spoken about earlier, I think is true for most agencies. Officers who have a passion and interest in this will gravitate towards these positions. But probably more challenging is to get the everyday line level officer to really engage with these programs and these kind of diversion avenues, I guess you could say. And that's because these are the people who didn't gravitate toward those positions, right? So maybe even most important that we reach those people. And I think there's a lot of ways to do that. And I think organizational culture is definitely a component of this conversation. And that is in the sense of how your organization values diversion and kind of how they may look at outcomes versus output. Because if we're really looking to get line level officer buy-in, I think one of the things we have to speak to is efficiencies for them, right? They have to be masters of being efficient, and maybe short term, it takes a little bit extra time to work through some of the diversion programs, especially the access points. But long term, they see the benefits because they have people that they'll respond to day in and day out, and then all of a sudden the person's in a program for a few weeks, so they feel it firsthand at the line level. And I think that so I think you have to come at it from two ways, and one is that the organizational values have to exist. We really have to understand that we're focused on evidence-based outcome versus output policing, and maybe even reevaluate what it means to make an arrest, that front end discretion, that front end police discretion, and as well make sure the officers understand those benefits that they're going to feel at the line level day in and day out when they invest in these diversion kind of off-ramping programs such as a CSU. So I don't know if that touches on what you were getting at.
No, that was great. Thank you very much, Lieutenant. I'll turn it back over to you, Rebecca.
Sure, thank you. And before I get more into this is the challenge with these events. We get like an hour and a half, but I mean, we could talk about this all day. There's just so much good stuff to cover. I wanted to actually go back to another of our panelists, Angela, and see if she could give us a little bit of background on her program.
Hi, I'm with the Behavioral Health Crisis Center. So we have 3 different parts to our Behavioral Health Crisis Center, and we're very lucky to have all 3 parts in one building, along with other services. We're part of a larger community service board that has adolescent, adult services, and we're all located in a very, very large building with our Behavioral Health Crisis Center on the end of the building. We have 3 different parts to our crisis center, which is the 24-hour crisis walk-in, and we utilize the peer first, peer last model, which the peer greets the person at the door and does just a very brief triage of why they're there, what they're seeking, and they stay with that person throughout the process. We have clinicians that are in the walk-in that can do assessments for those who are in crisis and may potentially need to go to an inpatient facility, or they may be referred to outpatient. We also have a nurse that does the basic vitals and medical assessment to make sure that someone is medically safe to stay in our lobby. We do accept detox as well, so they're there to make sure that someone is in a safe place. We also have a psychiatric nurse practitioner that's on staff 24 hours a day, 7 days a week. When someone comes into the crisis walk-in, they can get that assessment. If they are able to leave and go to outpatient, then the peer guides them, gives them referrals, and helps them leave the door. If they do meet inpatient criteria, we can go a couple of different ways. We have a 8-bed temporary observation unit, which is 23 hours or less. Some people stay more, some people stay less, and it can be used in a lot of different ways. It can be used to assess if someone needs a longer term hospitalization, or sometimes people just need to restart their medicine so they can stay, see the nurse practitioner, restart the medicine, and leave in less than a day. Or if someone has an insurance and they're not able to go into our facility, then they can be admitted to the temporary observation unit and wait for another facility who may accept their private insurance. So we're able to serve people in our temporary observation unit and our walk-in no matter what their insurance is, whether they have insurance or not. If someone needs inpatient setting, we have a crisis stabilization unit, which is 30 beds, and that average stay is 3 to 5 days. Typically, the person that would get admitted to the crisis stabilization unit is someone who has no insurance. We're considered the safety net for the state of Georgia. So we accept those who are not insured. Other facilities, if someone has insurance, there are other facilities that we can refer them to. And like I said, they can go in our temporary observation unit to stay if it was going to be a long time that they needed to transfer to another hospital. And we utilize peers in all three parts of our behavioral health crisis center. Like I said, the walk-in is peer first, peer last. See the peer, then leave with a peer. On the temporary observation unit, the peer can go and do individual with those who are on the observation unit. And we employ peers 24 hours a day on the crisis stabilization unit. They do groups, they do individual. And our peers are not just mental health, they also are substance use peers, as well as we have a forensic peer. So someone who's been in the justice system and has been certified as a peer, and she works on our crisis stabilization unit as well. And we accept referrals from all different kinds of sources. We get a lot of referrals from law enforcement. We are a 1013 receiving facility, so we can accept those emergency 1013s as well as OTAs, so ordered apprehends. We can accept it, and officers simply bring them to the walk-in, and then we take it from there. So they don't have to stay with a person. We accept that person, and then we go from there what we need. So we work very collaboratively with law enforcement as well as other facilities, because our referrals can come across the state. They do not have to be specific to our region. They can come from any part of the state into our behavioral health crisis center. And they can be self-referred, they can be referred by another provider, they can be referred by just seeing our sign, they can be brought in by law enforcement, they sometimes are brought in by probation or other recovery facilities. The domestic violence shelter can bring people in, so they can come in from any area of referral.
So if you're the safety net for the state of Georgia, do you get a lot of people from a distance away from where you are?
Our crisis stabilization unit does get a good amount of people from South Georgia. Our state of Georgia is divided up into 6 regions, and we're region 2. So we serve 10 counties in our area. Every region has certain safety net beds they can use, but we typically stay full, as well as the other parts of our region. We stay full. So as the state, we have a behavioral health link where if someone has no insurance, they can be put on a system that's accessible to all of the CSUs, and we can go through those referrals no matter where they are in the state and accept them based on what that referral is, and that's open to all the CSUs. So when we have open beds, we go to that board and we look through to see someone who may be an appropriate fit for our unit.
Thank you for sharing that. I also find it really interesting that peer support person you have who's got the justice system experience in there. I think that's unfortunately fairly unique.
It is.
So that'll be interesting to continue to watch and see how that works for you all. I kind of want to open this back up. This is a question for you, Angela, and for everyone. Your programs to get these off and running, you most likely started with a core group, a core team of partners for these collaborations. I just sort of want to ask how you all deal with the growth, because obviously everyone's working on getting these programs up and running, and then they start to work, and then you tend to see, or what we see is more people want to come to the table. So that's probably, I just kind of want to get into that a little bit about how you sort of manage your partners. Training, we did want to talk about that too. It's got to be a huge part of it because there's so many different facets to your projects. So if anybody wants to go ahead and start and talk about the cross training that they do and how they sort of manage the balance of having all these different partners involved.
I'll speak a little bit on that. When we first, like I said, we opened up our crisis stabilization unit in our walk-in center in 2009, and towards the end of 2008, when we knew that we were going to be receiving the funding, and as Sheriff Mayer talked about, Commissioner Williams and the Department of Mental Health has been very proactive and innovative to know that over these last several years that things have changed. But when we first started looking at implementing, we brought in focus groups from all the different communities to look at, NAMI, emergency departments, like she was talking about, Angela was talking about with the domestic violence centers, the residential substance abuse centers, and all of those, because time to time we'll have people that are brought in from these residential facilities. They get admitted and then they have a psychiatric crisis while there, so they can come for stabilization. So we knew that we needed to get their input instead of just saying, we know this is the way it needs to be developed. And so that was very helpful. I would say one thing that we did not really think about that we should have for anybody that's looking at doing that, because already twice now since 2009, we've had to expand because of the volumes. As more people are trained and the community realizes, that this is a very effective service, then as far as our walk-in, those numbers have grown every single year. And in the last 3 years have really grown significantly with the drop-offs. And with even further out counties, law enforcement will drive an hour to bring them to us so that they don't have to stay 10 hours in an emergency department in their home, their hometown or their county or their jurisdiction. And so that's one thing that we definitely did not consider. And we're also going to have to, and again, with Commissioner being very proactive, we're going to open another pre-arrest diversion 24-hour walk-in center in the next several months in our Northwest counties because of that, that reason. And so I would definitely think about that, the space needed for a walk-in center, because you have so many different acuity levels at one time in a walk-in center. And to be able to manage that, you definitely need to, have the different quiet area, low acuity areas, high acuity areas, and things like that. So over the years, we've definitely learned a lot about volumes and acuity and the appropriate space needed to meet the needs of these individuals.
Yeah, you definitely need to have a good bit of flexibility
Exactly.
to change processes and processes. Angela, did I just cut you off there?
No, you didn't, but I did have a thought. One of the things that we recently have begun doing more of is the discharge planning and discharge follow-up. We have a peer specialist who is following up with our discharges within the week after they're discharged, and we're going to start doing that with our walk-in as well. And what we have seen from the small amount that we've been able to do is that it is reducing the amount of people who are coming back for our services. We would love to double our unit. I mean, we could have a 100-bed unit and probably keep it full, but we're just not physically able to do that. But having a very strong follow-up with our discharges to make sure they are linking up with appointments that they have afterward. So many people, for whatever reasons, they have their appointment and then they leave and they don't keep them. So then they come back to us and it's just this revolving door. But having that one discharge person that can make sure they get to that appointment and they get set up has reduced some of the people coming back and needing our services, which opens up the door for new people to come in and receive our services.
Yeah, definitely. I think slowing down that revolving door is tough to do, but opening up that communication and making sure that's regular and consistent is a huge part of slowing that down a little bit. Back to that sort of when they come in, the handoff, the referrals. How do you manage or how does your communication go with law enforcement for those dropping off? Do they just, is it just they are received? I guess you, Angela, I'll start with you, because we already heard about
Right.
Tennessee, but they're brought in. Do you guys get a heads up as well, or is it just?
They can just bring them without notifying us. We also have some law enforcement driving an hour to bring someone to us to avoid even taking them to jail. If it's an offense that's related to mental health, they are bringing them to us for an assessment and treating that mental health instead of for small crimes, taking them to jail. They're able to divert them to us. A lot of times they do call us. The judges who do order to apprehend are very good about calling us and letting us know, and then we can hold a bed for that person. So when they come in, they're assured a bed. Law enforcement is very common just at our at Advantage, and we have several co-responding teams. We have 2 full-time co-responding teams with an LCSW and an officer. We have 2 sets, both during the daytime and the evening time, and we're expanding to having hopefully 2 more co-responding teams. And we work very well. We work very well with them as well, and they often are our referral source. We call them when we do need law enforcement to help us, as well as they're able to be a liaison sometimes for people who are coming to us.
How does the follow-up work? So you talked about the person who's dedicated to following up on the cases. Does law enforcement get follow-up from you all, or how does that work?
We still are bound by HIPAA, so it can get very tricky. We have to have releases of information in order to follow up with someone. Our director we have a director of justice who works with a co-responding team. So she spends a lot of time at the police department. She has an office there as well as an office at our facility. So we go through her if we need to share information, and she helps facilitate getting those releases of information for things when we need them. Sometimes, particularly for probation officers or law enforcement that are common in someone's life, they are willing to sign a release of information because they want us to let them know they've received treatment, but not always. We're working on having having a relationship of having a memorandum of understanding with the local law enforcement that would be able to help us communicate.
Yeah, I imagine it would be helpful on both sides to probably, even if we're not talking about direct follow-up on particular clients, but rather just sort of some general follow-up with each other to make sure everyone's sort of looking at the same thing. Are we getting the amount of people that you say that you're dropping off to us, and back and forth and things like that? Do you all have like a regular sort of meeting or communication loop that you all keep?
The director of justice meets and actually talks with the police department on a daily basis. She also participates. We have a number of treatment courts as well as drug courts in our area, and we have a representative on each of those. So we communicate regularly with them as well. There are weekly meetings with the treatment team, the treatment and accountability courts, as well as the drug courts. So our communication is
constant.
We're trying very hard to increase it every day because we need more and more and more of communication. But I think we're doing as well as we can given HIPAA laws and
What about you, Tennessee? How do you all sort of manage the statistics or counting or just talking about the numbers and program statistics like that?
One of the things that Sheriff was mentioning earlier is our law enforcement mental health collaborative with several of the agencies, social service agencies and law enforcement agencies, and our mental health and substance abuse agencies would meet together on a monthly basis. And part of that would be where, as long as we have one, again, what Angela was talking about is having to have that release of information. But we, towards the end of our meeting, we would look at those individuals with a high recidivism rates within our services, whether that's back in and out of court, in and out of jail, in and out of our walk-in center, different agencies, and be able to kind of talk about that and get creative and innovative and think about what's going to help, what are the barriers, what's going on that they keep coming back. And so, but it's still, you've got those individuals that are not willing to sign off on that. And so we did create a document where it's releasing their information to our collaborative in order for us to be able to discuss that information separate from our regular release, because there's so many agencies involved in that. However, we also have a memorandum of understanding with our law enforcement, but it really does not cover the specifics of releasing clinical information. And like I said, the only thing we do have there is if that patient is agreeable to sign that release that goes before that collaborative committee that addresses those needs.
Hey y'all, it's Marilyn. I don't know if this is a good time, but we have a couple of questions from the audience, if you don't mind if I jump in. So the first, okay, great. So the first one is about exclusionary criteria. Any exclusionary criteria you have for your CSU?
So for our walk-in center, which is part of our continuum that has the option of referring to our CSU, but our walk-in center, the only exclusionary criteria would be is if they come in and they have a major medical issue that requires some urgent care being taken care of. Otherwise, we do not turn anybody away from our walk-in center. We will go ahead and serve and triage them in and get the services that they need connected. As far as our crisis stabilization unit, the only ones that are not appropriate for those, the way it's written in our state is for our crisis stabilization unit is completely voluntary. And so we do not take them on the crisis stabilization unit on a involuntary commitment. In our walk-in center, 24-hour walk-in center, we do have people that are brought in. The state of Tennessee, for the commitment, has a 3-step process. Part one is detaining them for a mental health evaluation. Part 2 is the mandatory pre-screening agent feels like that they meet that involuntary commitment. And then the part 3 is a receiving site agreeing with that after completing a full psychiatric evaluation. And so for our walk-in center, we will manage those individuals on a part 1 and a part 2 while they're waiting for the most appropriate involuntary commitment placement. And like Angela said, we take all, we're also for the state of Tennessee, the safety net provider. And so we take Indigent Commercial, our TennCare, which is a Medicaid program that we have. And so we take everyone, regardless of ability to pay or anything.
Marilyn, I can jump in really quick if you like regarding same question. Yeah, you will. Well, if you don't know already, the cops always know what the exclusionary rules are. because it goes like wildfire as soon as they find out. So, along the same lines, it's acute medical care, people under the age of 18, organic brain syndrome, medically unstable withdrawal, recent history of self-harm or violence towards others, or someone who just kind of lacks the ability to comply with basic rules because it is kind of an open, environment. So those are some of the key ones I know that our officers are very aware of.
That's great, Lieutenant Hill. How about in Athens, Angela?
Those same things, although we can accept people who are involuntary and we can go through that involuntary process. We have a very good working relationship with our local hospital. So we sometimes send someone out to get medically assessed and treatment, and then they can come back to us if it becomes acute. So we can't take individuals who need assisted care, such as catheters or dressings that need to be changed, but we can take health conditions, sometimes even unmanaged, like diabetes and cholesterol, those types of things. We also cannot exclude someone if they're COVID positive, as long as all other criteria is met for admission. If they are under age 50, if they don't have any acute medical issues, and they would normally be admitted to our unit and they're COVID positive, then we have an isolation area that they are admitted to, and we staff that with full PPE. We staff that with a staff, and they're isolated from our unit during their quarantine time.
Wow, that's great. That's really great. I'm curious, just a quick follow-up. Are there any charges that would be excluded? Any specific charges to any of the CSUs?
We have not. It's not in our policies to exclude based on any kind of legal charges. If we are to hold them and they return to jail, then we have to have a specific hold order. We can't hold them just based on word. We have to have a specific court order to hold them and return them to jail. But we have had some major offenses of people being admitted to our unit.
We're the same way as it relates to charges. There's not anything that's on our exclusionary criteria. And the same with the detainers. As long as we have that court order in place, then we're able to provide the service and then hand them right back off.
Yeah, that's really great. Thank you. So if anyone else wants to enter a question, we do have a few more minutes. Please feel free to enter it into the Q&A. But in the meantime, we do have another question. This is for Sheriff Mayer. Do you collaborate with Mental Health Center to put information into the CAD system about a person's mental health history?
Yes, we do. I mean, that's important. And I was sitting here thinking about that. The dispatchers are very important part of this mental health group, because lots of times they are the first person that receives that call. They know a series of questions that they actually get to know lots of these people because they're frequent flyers calls, but it's very important that you put it in the CAD. Therefore, call comes in and they have a certain address, it pops up, they know who that person is when that call comes in on the 911. So they can actually then give the officer that information, what's going on. And we live in a world today about how officers react, but that officer gets that call from dispatch to find. Our response is pretty quick, but they already know a little history there. They know that lots of them have worked that area, know that person. So that communication back and forth between dispatchers and we not only use it for the crisis part, but if they're medical, encourage citizens to let us know if you have somebody at this location that has heart problems or whatever. They may even be that in there and sign that release, go ahead and we'll put it in there because if somebody comes in, medical attention, not only sending the officer, but that's kind of alerted there may be a response. That all works together, and I think that's it. Officers last year, I don't know how many suicides that they have, attempts they have used before it ever happened, off the person out. Not just one officer, several officers. Having that knowledge and that training. I'll go back to one other thing real quick. On the CIT, I can tell you within the first couple of days, some of the officers said, "This is not for me. I want no part of it." They'll stay into the program, get out on the street, come back and say, "This works. Tell other officers, this works." The officers wanting to volunteer, put in for whether it's our officers or others, they will say, "I want into the class." So word of mouth, it's seeing best stories in order to build the program.
Yeah, I think that's super critical. I mean, we obviously have to have buy-in at the top, but it's so also necessary to have that line level buy-in from your law enforcement as well as your mental health workers, your staff there. I know that when you have line level officers and you have mental health clinicians working together and who understand each other as much as they can, it makes both their jobs just so much easier. Or less challenging, maybe that's the right word, because it's difficult work. We missed several of the themes here. I feel like we just got so caught up in some good Q&A. Maybe to wrap it up, maybe if we could just sort of do a general, if you have some thoughts that you want to share on what's working really well with your CSU, and or also maybe what are some things like the next thing that you all want to work towards. If you can just wrap that all up into 30 seconds, that would be great. I'll start with you, Sheriff, since you were just talking, and Kim.
All right, there's a lot. Every day is a new day, and we're always thinking and coming up with new ideas what we'd like to do. Of course, lots of it has to do with funding. Everybody knows that's the number one thing, and if you don't have funding, it's not going to go anywhere. The stories, and hopefully we've got to look more in the mental health field, and we've got to sell law enforcement. That's the key too, is that's selling them that you're here and you're going to be the first one on the scene. I think nationwide that's important, especially in this day and time. Sell that to officers and if they can communicate with somebody else who's been doing it and say it works, so we'll see the culture change and all. And everybody has to work together, like mental health, just like the ER. Our officers and the doctors at the ER know our people. So that's important. I mean, it's that communication and that working together. Not one group, one person, all part of it.
Thank you, Sheriff. What about you, Kim?
I was just going to say, I think one of the things that we would really want, that we're wanting to expand to is, I talked about is kind of piecing together a co-responder model as needed. but to have a dedicated co-responder model, that is one thing that we're striving for. And I think it's very important to have that, because there's sometimes it's better to go ahead and resolve things out there in the community as opposed to bringing them in. And so we've seen that when we've kind of put it together on special individuals, then it's really worked well for us. And so in our area, we have many developmental and intellectual disabilities group homes, and we deal with a lot of things there from the mental health and law enforcement side. And so if we had more of a co-responder model to address those things with those staff and everybody there, as opposed to that individual coming in, because it tends to, it's a lot of times it's a treat for those individuals with developmental to get out and come to another facility. And so they do that on a regular basis because they get to get out and come to another facility. And so those are one of the things that, not just with that, but other things that we've seen work really well with kind of putting together that co-responder model. The other thing that we're working towards now, we're writing a grant specifically for what Angela was talking about that they're already doing, is starting doing the discharge planning and aftercare planning and follow-up, more than just one phone call afterwards. We want to have a more intensive follow-up service when they do leave our walk-in center, so that we can help reduce those recidivism. And so I think that's one of the things, trying to fill in the gaps. Sheriff, we've talked about the collaborative effort, that's gone really well. The services that we provide are very well, but I think that follow-up is so key to reducing the recidivism rates of the individuals coming back through our walk-in center. And so those are some of the two things I think, but just out there, anybody thinking about starting, you really can't start without pulling together that collaborative effort, because you can have a service all day long, but it doesn't work as well unless you collaborate with all the community stakeholders.
Get a strong core team together. Yes.
Rebecca, can I say something just a minute?
Sure.
Under the learning sites, and in Houston, just one that came to my mind. Houston started with their unit, and they took their most 100 users of the system that had mental problems, but they came in and started taking those 100 most used people, started making calls or visits, start with, and then for a day or two they'd make a call. How are you doing? Are you staying on your meds? Are you doing this? Are you doing that? And then they break it down to one day of a week, and what happened is they drastically saw the decrease of those callers, and that stopped all these unnecessary calls to law enforcement. But it's just that, kind of like Kim was saying, it's a follow-up. And those people, lots of times, I know I get the calls, they just want somebody to talk to, or somebody's willing to listen, and they're good. A month from now, they may call back, but you've got to continue to work with them, and they feel like they've got a friend going through a crisis on a call.
Yeah, that's really thinking through your high utilizers can be a big deal for collaborations. So
right.
Sounds like you guys are already on it. You're working towards shoring up that follow-up and that preventative type of action that you all can take. I just want to give Lieutenant Hill and then Angela a minute to share anything.
Rebecca, in 30 seconds or less. I guess there's two things I would just say really quickly. One is organizational communication, I think, is key. The officers really need to know that this is not a check the box program we're trying to do. We're really reimagining how we work with these community members and how we can best serve them and support them. And that doesn't always equal an arrest. So they need to hear it and see it from the organization. And the second would be access points. The how the CSU can really accommodate the officers in whatever way they can for access points, because our CSU and our jail are almost right beside each other. So I can tell you right now, if there's a lot of barriers on access points for the CSU, they're going to turn right instead of left. So really kind of giving the officers a little bit of a voice in responding to their challenges is helpful for implementation.
Thank you, Lieutenant.
I think just one point, the thing that has helped us some is knowing resources. Athens has a lot of resources, but our outside counties typically don't. And a lot of people are utilizing the crisis services to meet their needs when their needs could be met with some outside resources that maybe they don't know about.
Thank you, Angela. Appreciate that. I think I'm going to kick it back over to CSG to talk about next steps after this. Thank you again very much to our panel. I could talk to you guys all day, all week. So much great stuff to offer. And like I said, we missed a few of the themes, so we'll have to get back to it another time.
Thank you, Rebecca. And I just want to, respect people's time and note that we have reached the ending time for this webinar. I have a few final announcements to deliver that will take about 3 minutes, but we understand if some of you need to log off and want to thank you for attending. And a big thank you to our panelists. For those who can stay, Eunice, if you could advance to the next slide. Here are some resources that relate to today's panel discussion. We've linked to these resources in our slides, and these slides will be made available on the CSG Justice Center website, along with a recording of today's webinar at the end of next week. Also, the National Police Foundation and the CSG Justice Center will be publishing a 2-pager encompassing the key takeaways from today's panel discussion that will be published for the field, and this will be placed on the CSG Justice Center website as well when available. Next slide. And this is simply an announcement about a virtual event coming up on May 20th. The event is called Taking the Call, and it will be also a panel discussion with representatives of innovative programs across the country, redefining who responds to behavioral health calls for service and quality of life calls. It's going to explore how these models may improve community health, lessen burden on law enforcement, and reduce unnecessary justice system contact. The registration link is found on the CSG Justice Center website. It's going to be presented by BJA, the CSG Justice Center, and the University of Cincinnati. Next slide. And this is our contact information. If you have any questions about today's webinar, feel free to contact us at our email addresses. These are the CSG Justice Center contacts and the NPF contacts. And the panelists were very kind to also share their contact information with us for attendees. And finally, this is another reminder that this webinar was recorded and will be posted along with the slide deck on the Justice Center website. Thank you so much for attending.